Hello everyone, welcome to NG's Corner for Nurses. Hope all of you are doing well. Needle stick injuries are frequent occurrence in healthcare settings and can lead to serious complications. While the introduction of universal precautions and safety conscious needle design has led to a decrease in needle stick injuries, but they still do occur. Today we will discuss about the needle stick injury. We will cover this topic in two parts. Today we will discuss the part 1, that is the concept of needle stick injury. This is the outline of today's video. Let's start today's discussion. What is needle stick injury? Needle stick injury is a percutaneous piercing wound typically set by a needle point, but possibly also by other sharp instruments or objects. So we are saying needle stick injury is a piercing wound that is set by needle point or by other sharp instrument. So what do you mean by sharp? Sharps include needles as well as items such as lancet, broken ampulle, razor blade, scissor, metal wire or pins. Essentially any object that is able to cut the skin can be considered as a sharp. Let's see what are the devices involved in needle stick injury. Injection needles, suture needles, scalpel, broken ampulle, razor blades, scissor, metal wire or pins, or any instruments having sharp tip or edges. Who are at risk for needle stick injury? Like physicians, nurses, laboratory staffs, technicians, support personnel, all the healthcare providers can be exposed to needle stick injury, even who have not direct contact with patients. If the used needles was not disposed properly, may injure the workers who handle the wastes. Let's see the causes of needle stick injury. Not using the safety engineered sharps or using them incorrectly, recapping the needles, transferring a body fluid between containers, and failing to dispose of used needles properly in puncture resistant sharp containers. Why should we be worried regarding needle stick injury? An injury from a contaminated needle exposes healthcare workers to blood-borne pathogens that can cause serious infections. The most common pathogens are HIV or human immunodeficiency virus, HBV or hepatitis B virus, and HCV or hepatitis C virus. The risk of transmission for HIV is 0.3%, for HBV is 6 to 30%, and for hepatitis C virus it is 1.8%. Let's see which body fluids are potentially infectious. Blood or serum or plasma, semen, vaginal secretions, body fluids like synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, amniotic fluid or cerebrospinal fluid. Laboratory specimens that contain concentrated virus, and apart from this, other body fluids contaminated with visible blood. Let's see the factors that influences the risk. First is the amount of body fluid involved in exposure. Next, size and type of the sharp instrument. Third one is depth of injury, and the fourth one is amount of microorganism present in the fluid. We are using a word exposure. Let's see what are the conditions which we consider as a exposure. First one is contact with potentially infectious fluid to non-intact skin. Second, puncture skin with sharps which is contaminated with potentially infectious fluid. And third one is splash of potentially infectious fluid to eyes, nose and mouth. And what is not an exposure? Puncture with clean needle, blood or bloody fluids to intact skin, and splash with non-infectious fluid. What we will do if there is a case of an exposure. In case of punctured wounds, immediately wash the puncture site and surrounding skin with soap and running water. Don't use antiseptics. And for splashes, flush the splashes to the nose, mouth or skin with water and irrigate eyes with clean water or sterile irrigants. Then inform the in charge or supervisor on duty. Incident report raised with detailed description of the incident. Visit the staff clinic or emergency medical officer on duty, and the incident form should be duly signed by the departmental head. Next, coming to the sampling. If the source is known and serology is not done for the patient, then immediately collect 10 ml of sample from the source and send to microbiology department, and 10 ml of blood sample from the exposed staff member should be collected in the blood unit and sent to microbiology department. If the source is infectious, the post-exposure prophylaxis should be started as soon as possible. It should be initiated within 24 hours and not later than 72 hours after exposure. The next step is follow-up. Any staff who has potentially been exposed, whether or not post-exposure prophylaxis has been started, should report to the staff clinic or infection control department for follow-up as per schedule. For HIV testing follow-up, the follow-up period is respectively 3 weeks, 3 months and 6 months after exposure. And for hepatitis B virus and for hepatitis C virus, the testing follow-up period is 3 months and 6 months after exposure. Next step is counseling. Exposed healthcare personnel is advised to use precautions, especially the first 6 to 12 weeks post-exposure. Following measures are to be adopted: refraining from blood, semen or organ donation, abstinence from sexual intercourse or use of condom. Women should not breastfeed their infant, and the exposed person is advised to seek medical evaluation for any febrile illness that occur within 12 weeks of exposure. To memorize the action points after an exposure, we can use this word WIN. W for wash the exposed site, I for identify the source, and N for notify to the infection control team for the management of exposure immediately. Next part of this topic, that is the prevention of needle stick injury, will coming soon. If this video is useful for you, then it is requested to put a like and share it with others. And for getting more videos like this, you can subscribe my YouTube channel or follow my Facebook page NG's Corner for Nurses. And for any queries or suggestions, you are most welcome to comment. Thank you for listening.